So you know those basic major SSRIs, Lexapro, Celexa, Paxil, Zoloft, Prozac. Prozac is approved for children. I'm not sure if you ever use drug guide. I think it's useful for just anybody, except I wouldn't let kids read it too much. But if you ever want to know the mechanism of action to explain in terms that kids can understand or parents can understand, you can find, maybe you can purchase just one for the department. And since now you know a little bit about it, all you have to read is SSRIs, you know what it does, what is approved for, and for major depression, it is approved for kids ages 8 and older, and how it works, how long it takes to see a clinical effect, and then side effects, and if it doesn't work, what to do about it. What are the supplemental medications can be added to it. You can make recommendation to see a psychiatrist. You can make recommendation to see a pediatrician. If you see that something isn't working and you know that you've done everything you can possibly, maybe it requires a change of medication. Maybe it requires augmentation with a different medication.
I'll tell you, a lot of our kids have depression and anxiety combined, and sometimes it's really hard to tell which one is creating the worst effects in their lives. So a lot of the doctors, though, I see the kids that have horrible anxiety, they put them on an SSRI, but nothing for the anxiety.
SSRI is approved treatment for generalized anxiety disorder. Okay. This is the first line treatment. I bet everything that no psychiatrist in the right state of mind would ever prescribe benzodiazepines unless the kid has severe panic disorder. There are other medications they can try. They can try hydroxyzine. They can try Benadryl. Sometimes Benadryl has opposite effect on kids. It excites them more than it calms them down. So parents, they have to watch for that as well. There's another one.
A lot of our kids are on benzos.
They are on benzos, which is unfortunate.
Don't a lot of kids take like 10x?
Yeah, sometimes it is. Yeah, yeah. I probably would stay away from benzos for as long as I can. Mm-hmm. For performance anxiety, beta blockers would be propranolol. It can slow down the heart rate, except for kids who have asthma and if they take any kind of inhalers, because propranolol is a beta blocker. It's going to block certain cells right here, so nothing can really expand. And they're not going to hyperventilate like crazy when they're going to perform, right, before exams. But if this kid has asthma and needs to use the inhaler is not going to open anything up because beta cells are blocked. So it is contraindicated, absolute contraindication for kids with, or for anybody with asthma. And I have seen people with asthma prescribed beta blockers. What are the doses of benzodiazepines and what are the benzodiazepines being prescribed?
They're on usually 0.5 of
lorazepam, Ativan.
Mm-hmm.
Okay, Ativan is a fast acting versus clonazepam is a slower acting. So probably lorazepam requires more frequent administration during the day versus clonazepam maybe twice a day administration. What lorazepam will do, let's say this is, it's going to act like this. It will take care of your anxiety, but then again, it's going to leave your body fast because of short half-life. Half-life is how much medication, how long it will take for 50% of medication to leave your body. So that's half-life. So it's relatively short half-life, up and down, and then they're anxious again, and then they get used to benzodiazepine, and they get used to it, and they develop tolerance and resistance. They would need more, and not resistance, dependence. And they would need it, really. It's a psychological and physiological dependence. Clonazepam works different. It doesn't give you this high immediate, kind of creeps up slowly, but then it keeps it up leveled, and the short life is longer, so by the time it started going down, it's time for next administration of clonazepam. So it is pretty much leveled instead of up and down, up and down, and up and down. And then again, it's reward if they feel, oh, I feel wonderful now, I took benzodiazepine, why not take it again, why not take it again? By the time they start drinking, because anxiety was never treated, in combination with benzodiazepines, it can be deadly. So that's why I would just stay away from it. Or advocate, you can talk to parents and say, is there a better way? Buspar is another, it's not as effective, it's not going to give them that high or that not euphoria, kind of just, you know, I don't have to
I think
deal
I've
with
ever
daily
seen a
life.
kid on who's-
You have not? Usually twice or 3 times a day administration. Maybe that's why. They're in school in the middle of the day, but it can be administered twice a day. I would probably start with hydroxyzine, probably start with bedtime dose, because who knows how the kid is going to be affected. Probably start when kids are on break, they're not in school, so you don't have anything, any unpredictable behaviors in school as a result of the new medication. So, but SSRIs are approved for treatment of generalized anxiety disorder. No one on Xanax.
Maybe I can't.
It's very difficult to taper. It's very difficult to stop taking Xanax. All of them dangerous in terms of severe, acute withdrawal can result in seizures. And so maybe if we're talking about benzodiazepines, let's talk about this neurotransmitter, GABA. It's a major, we call it inhibitory neurotransmitter. It kind of inhibits everything. So benzodiazepines potentiate the effect of GABA neurotransmitter, so making people feel calmer, not, oh, there it is. Benzodiazepines act by enhancing GABA effect. Caffeine will have opposite effect. It will inhibit GABA release. Benzodiazepine will potentiate the release, then caffeine will inhibit the release, and thus it will cause more excitement. So prolonged use of benzodiazepines causes adaptation of receptors, and this will increase number of receptors and sensitivity. So that's how they develop tolerance. They need larger doses for the same effect. So eventually those doses will not be effective. So the kid is, let's say, 10 years old and they're on 0.5, give it several months, kid will need 1 and more, and it's not going to be effective. Doctors will discontinue, because who wants to prescribe 2 milligrams of lorazepam to a child, to a school kid, and risk of the kid being unsafe because kid is falling asleep? No one. So that will be discontinued. So basically the treatment for anxiety never happened. They treated the symptom, they never treated the root cause. And probably root cause was somewhere in the family system. So withdrawal, let's say a child he'll forget to take the medication. He'll forget the larger dose of benzodiazepine. They can go into seizure withdrawal. Because now nothing is going to potentiate the effect of GABA, and nonetheless you have so many receptors, and pretty soon they can go into seizures. So dopamine. It's another inhibitory neurotransmitter that paradoxically produces arousal. 20%, if 20% dopamine depleted in the brain, then it can result in Parkinson's disease. Schizophrenia, there is a possibility, one of the theories, that overstimulation of one of the receptors for dopamine. So there's an increased amount of dopamine causing psychosis. 10% of Parkinson patients are giving dopa treatment, which they're treating them with dopamine. So theoretically, I think we talked about it during that presentation, that with Parkinson's disease, nicotine can be treatment, because remember, it blocks all those receptors causing more dopamine. But again, of so many unhealthy side effects, probably it will be a long time before it is recommended. Or maybe they just need to do something with it before they can recommend the treatment. But theoretically, and I think in a couple of cases, even practically, people who smoke and they have Parkinson's disease, they temporarily have some relief of symptoms. So theoretically, possibly due to that mechanism.
What about like those new e-cigs, like those electronic cigarettes, like the vapor stuff? Is that any better or worse, or?
No one knows. Theoretically, they think it's better because vapor does not cause as much damage. It's not an approved smoking cessation treatment because it glamorizes smoking.
Mm-hmm.
Still cannot be sold to underage kids. I think it's still 18,
Yeah.
that they cannot sell it. The danger of it, you don't really know how much you smoke. They can buy one-time cigarette, like a trial cigarette. It has 400 puffs, which equals to what? A pack?
2 packs.
2 packs. Okay.
Come on little lanyards and wear them around their neck with
Different
cool
colors and different flavors.
And different flavors, so it's
Super
nothing but
ridiculous.
glamorizing smoking. That's why it's not approved. That's why I would never recommend it. Sometimes I recommend it to adults, with severe COPD. So you have to choose lesser evil. And in my mind, it is lesser evil, but no one knows how much damage is being caused by vapor versus inhalation of smoke. You're still inhaling nicotine, though. So nicotine is still working on blood vessels, creating those unnecessary blood vessels, still blocking healthy arteries or healthy blood vessels. So in that sense, it's not any better.
Does it still have all like the chemicals, like the
No, because there
formaldehyde
is no
and-
filter.
Okay.
You're just inhaling pure nicotine. There are some positives because you can buy cartridges
Mhm.
and they all come in different concentrations. So if someone really wants to quit smoking, of course I can't make this recommendation because it's not approved as a smoking cessation, but to a friend or whoever, if you guys smoke, you can try it. You can buy maximum concentration, and then there is a medium, and there is small, and there are none. And you can start with mixing high concentration and medium, and you will never know which one you're smoking. By the time you're done, you can buy medium and small concentration, mix it up, and you will never know which one you're smoking. And when you're done with that stage, you can buy small concentration, low concentration to none, to empty, to fakes. Mix them up, and if oral cravings still persist, people can continue to smoke without anything, without any nicotine. Sometimes people use Nicotrol inhaler. The principle is the same. They inhale the nicotine.
Yeah.
And sometimes they just suck up this mouthpiece and there's nothing in it and can just sit like this all day long. It looks unsightly, kind of dumb, but if it helps people stop smoking, I'll go with it. So marijuana will decrease levels of dopamine. Nicotine will make more dopamine. There is another neurotransmitter, acetylcholine. Mainly it is located in the peripheral nervous system. Usually it's excitatory. Responsible for to stimulate skeletal muscles to contract. So a certain snake venom will block some of the receptors causing the paralysis and ultimately causing death. We already talked about GABA receptors. Another one is glutamate. It's in abundance in the brain. Always excitatory neurotransmitter. If kids use drugs and maybe they use PCP, I'm not sure any of them.
Got one
That's
kid on,
yearly.
one acid kid, one kid, a lot of kids that use smoke marijuana, tons of them
Okay.
smoke marijuana.
So PCP binds to those receptors and they can induce psychosis. So whenever you see psychosis in kids, first thing I would think would be drug use. Even if parents say, no, my kid is clean and it's impossible for my child to use drugs, then I would think some kind of a medical condition. I would not really think in terms of schizophrenia or in terms of bipolar right away. First thing normally would be drug use. You can send them to do UTOX. Some kids are very smart how to make false positives when they do urine toxicology. I would really do blood work instead of UTOX because they can do so many things to make it, false negative. And then probably this thing is important when it comes to talking to parents, why therapy is important, why treatment is important. One absence of treatment will result in more symptoms. The younger the brain, if the brain exposed to any kind of negative environment, let's say too much stress, or too much of certain neurotransmitter, or the neurons can be excited to death and die. And if they die, really there is no way of bringing them back to life, so to speak. And those neurons, they look like, imagine the tree with many, many, many branches. And some branches are healthy and some are not. And sometimes some are overgrown and you really have to prune the tree, right? Prune those branches to make the tree healthier, for the tree to develop better roots. So this process is called pruning. Whatever activity, like helpful activities that kids participate, let's say learning, exercise, healthy environment, medications, therapy, extracurricular activities, schoolwork, this will prompt healthy pruning. Anything that's unhealthy the kids are exposed to will prompt unhealthy pruning. And this can be pruned to death. Basically, cutting the whole top of the tree, and that this tree is not going to grow anymore, and this tree is not going to communicate with the next tree. So we say use it or lose it, so either you use your brain or you lose the brain function. And kids will understand that, and I think parents will understand that as well.
The other, you want to tell her about your kid is on gabapentin. What did they put her on? Neurontin.
Neurontin, gabapentin is the same thing.
What were they thinking they were doing for her, putting her on Neurontin? Do you remember? Yeah.
Well, she hasn't been diagnosed with bipolar, but that's what they're assuming, and so then they put her on that
For bipolar?
supposedly for depression, but then that's not what it's for. So
Not really approved for depression, not really approved for bipolar. It's it's a seizure. It's an anti-seizure medication, just like many of bipolar medications. This is the least effective of all medications for bipolar disorder. All mood stabilizers, this one is least effective. It is approved for neuralgia, for any kind of pain, neurologically related, and partial seizures. It is really not approved. It's an adjunct to treatment for bipolar disorder. It's a very mild anti-anxiety medication, very, very mild. So if it's sole treatment for bipolar disorder, most likely it's not going to be effective. If you see severe mania or acute mania, the best medicine would be lithium. Keep in mind with lithium, it's very deadly in overdose because it has, we call it narrow therapeutic index, meaning we have to check blood levels very often because little increase can cause toxicity, not enough will still continue, people will continue to exhibit symptoms. But even though it is deadly, it is very, very dangerous. And overdose, even by itself, it is approved to treat people with chronic suicidal ideation. But you just have to keep an eye on it. But again, thinking that this is lethal in overdose and it's prescribed, I will not prescribe it, knowing that it's lethal in overdose because kids can grab Tylenol and overdose on Tylenol and it's as deadly. So any over-the-counter non-prescription medications can be used in overdose and be as deadly as anything else.
Tell her what mom is doing with all of her meds. Just she's
breaking them apart and what did she say she was putting in baking soda or something?
cornstarch.
The cornstarch in her pills.
What is she trying to, like, placebo effect?
Yeah, because she said she's worried that her kid will get mad at her if she takes the medication away. So she's.
Isn't it better to just set up a session with a psychiatrist? Or really-
She's been referred to an early onset psychiatrist, and the date keeps getting pushed back. And so this was, in her mind, a way of, I don't know, I can't remember which doctor prescribed it, but it's her way of trying to maintain control until they go
Anything
and see a
that is
psychiatrist.
stopped abruptly may not be pleasant for the child, but it looks
Right.
like this kid has been off medications for some time. Did she notice any change in behavior or?
Yeah, there's a lot of change in behavior. I called Mom. I've been very concerned. Actually, there's more depressed and
Is that-
up and down with looking like mania, and then severe depression.
So the kid is rapidly cycling.
Yes, and
between
heightened suicidal
high-
ideation and.
But you're mandated reporters, so if I knew that something like this is going on, that they're vulnerable, it's not vulnerable adults, so I would involve Child
You would?
Protection Agency because technically she's responsible for providing treatment. If she doesn't agree with treatment, she needs to speak with a doctor and see what treatment is available. In absence, I wouldn't look at it solely like kid is prescribed this medicine, you absolutely have to give it. No.
I think she told me she's been talking to the doctor, but I didn't ask specifically if she shared with the doctor that she was putting cornstarch in them.
Yeah,
So.
this is ridiculous.
Right.
I will look at symptoms, and if if you see symptoms that you know that this kid needs to be treated.
Mhm.
In the absence of symptoms, let's say they stop the medication, who is to tell the mother that her child will be taking medications for the rest of her life or his life? I probably would give a hint that maybe it's a possibility, but I would really say, well, for the rest of your life, this child will be taking Neurontin or whatnot. No, probably with therapy, with youth support, with any kind of supportive services, maybe they can grow out of it. Maybe family environment will change. Who knows what will change? But for the time being, they absolutely have to have it, especially with chronic suicidal ideation. If you document that, you absolutely have to report it. Because then its liability would be on you guys. You knew it, you didn't really help the child, and you're supposed to advocate for those kids.
Even if you're talking to the parents, though, I thought at the end of the day, if I'm communicating all of my concerns to the parent and they're still refusing to take her to the hospital or do anything, because that's what they told us last week, that we can't hospitalize a kid without a
You
parent's
can
consent.
hospitalize the kid, but you can get child protective services
That's true.
involved. Let's say the child commits suicide or hurts himself, who's going to be responsible? They would look at your documentation.
Mhm.
The mom ever indicated to you that the child's suicidal? Kid ever indicated to you that she or he wants to hurt themselves? They're really asking you to help because they have no power against their parents. But you are on their side, and hopefully the parents will be not on the opposite side and still on your side. And that's how you talk to them and explain why those medications are there, why they're necessary. They're not happy with side effects. Instead of stopping abruptly, because all anti-seizure medications, which are all medications for bipolar, stopped abruptly can cause seizures. You're just kind of suppressing that excitatory activity with those medications. All of a sudden, you don't have those medications. Guess what? Seizure. Full blown, and the kid doesn't have seizure, and now the kid will be put on anti-seizure medication for a different reason, probably for a long, long period of time. Because who would want to risk that? No one. And in reality, the child never needed anti-seizure med. So I would be careful. Do you have any other questions about meds? If I can answer.
What about kids with ADHD that have really adverse reactions to stimulants? Like they're prescribed Adderall and Strattera and Concerta, and it makes them just like wired and angry and irritated. But that's the diagnosis, so that's the treatment they keep kind of cycling through. Do you guys ever see that here? Yeah, just kind of cycling through all the stimulant options.
If that's the diagnosis, that may not necessarily
Right.
should be the treatment. The treatment can be, let's make school more structured. Let's give this kid permission to take more time during the exam. Let's separate that kid from the rest of the group during the exam. Let's pair this kid like one-to-one with someone who is going to be with the kid during the school day. Let's see what can be structured in the home environment. I would probably keep a journal of some kind and see if child's behavior is different at home versus at school. And if at home is different, then school is the problem. They would adjust that environment. If at school is better and at home is worse, then I would really look into home environment and see what's making this kid behave in a certain way. Is it lack of structure? Because these kids suffer tremendously from any change in structure, any lack of structure. Is the kid sleeping enough, eating enough? Probably not eating. What if kid is drinking those stupid energy drinks? What if they're using drugs and parents don't know about it? So it can mimic ADHD, but nonetheless, it doesn't need to be only with medications. Only with medications, it's probably not going to be treated at all. And remember, we had this conversation, we had this discussion, can they be, does it have or does it not? So can we produce more neurons because some die, some not? And those that die, can we regenerate more? And it used to that, no, we can't. We're born with a certain number, and when they die, everything dies, and we cannot regenerate more. But now they're looking at it in different light, different perspective. They say, yes, it can be stimulated throughout life by learning, by exercise, psychotherapy, certain medications, and what we call growth factors. So let's say a little area right here died. Can we still restore it? And now they're saying, yes, we can. Let's say this neuron is going to, it's unhealthy. We can let it die, or we can apply those couple of things and what we call growth factor and make it grow back and bring it back to health. So not every illness needs to be chronic, not every illness is untreatable, so the illness of a neuron not necessarily untreatable or deadly. And that's when this mother takes her child off of this medication. You can tell her that that's what's going to happen. You really have a chance to still form healthy connection or have this child experience less symptoms. With the young brain, if they're exposed to toxins, and they are, every time they experience mania, depression, think of it exposure to toxin. It causes more damage, and the younger the brain, the more damage it causes. The younger the brain, the longer lasting, the more devastating damage it will be. And with every new episode of mania or depression that you see, the next treatment will be even more harsh. And let's say with the first treatment, they experience relieving symptoms in 2 months. The next time they'll be hospitalized for 4 months. Next time that they let go, will be hospitalized for a whole year. Before you know, they'll be committed. Before you know it, they'll be at Anoka for a long, long time. So talk to them in terms of kind of scientifically what's going on in the brain, how neurons die, what medications do. And you can read with them. You can print it off probably from Mayo Clinic website. Do some printouts. You don't have to have a drug guide per se, but if you have it, I think it's very useful. You don't have to let them read the whole thing, but you can let them read just part of it, whatever you feel important. Some can be transplanted, some neurons. So some can be brought back to life, some can be transplanted. I don't know if you have any interest in learning how serotonin is being produced. And some people say, well, if you eat enough serotonin-containing products, then you'll have more serotonin. You will not. Serotonin is being produced in the brain, really. So some people say somewhere in whatever part of the world there's a tribe, they eat lots and lots of bananas, and they're very happy people because bananas are high in serotonin. They are high in serotonin, but that's not the serotonin that will be available to the brain. So in order to produce serotonin, you need some, that's like a recipe. You need tryptophan, oxygen, iron, and tryptophan hydroxylase. There's some truth to it. When people eat something sugary, then it's going and containing serotonin. Serotonin will get to the brain. It will not by itself. So it has to do with insulin production. When people eat carbohydrate, then insulin is being secreted. So insulin is like a little car. So the carbohydrate will sit in this little car, and all those large molecules will sit in the car and they'll be taken into the muscle cell. So the free form of serotonin will be in the bloodstream, and it can easily cross blood-brain barrier and get into the brain where serotonin will be synthesized. The final product is not serotonin. The final product, because serotonin in the brain will be metabolized into melatonin. And that's when people feel sleepy. And that's why if they have too much melatonin, it can can cause seasonal depressive disorder. That's why exposure to light, because light is going to disintegrate melatonin, immediately making serotonin more available. And that's why people experience some relief in symptoms with seasonal affective disorder with exposure to light. I'm not sure how you conduct your assessments when you work with kids, but you can, just by looking at them, can probably spot some medical conditions or kind of do I don't know if you're training, if that was ever part of the training. No? You would never do that, right?
We could.
Like, a kid is complaining of a headache. What would you think?
They didn't eat.
They didn't eat? Or they're exposed to cigarette smoke, they're exposed to abuse. Maybe there's some drinking at home, right? Maybe they're exposed to stress, developing vascular headaches. So that kind of would be then your expertise to see what's going on. So not necessarily the kid has migraine headaches and needs to be treated by a neurologist. For example, if someone is presenting with asthma, for anxiety. And asthma can mimic anxiety. Let's say the asthma was not diagnosed and the child would present to you with anxiety and will be treated with some benzodiazepines, for example. And in reality, the kid is not moving enough oxygen in and out. And let's say asthma is in the very beginning stage, being undiagnosed. So don't assume, we shouldn't assume that it's a psychological problem or it's immediately a psychiatric problem. I first assume that it's a medical problem. So, and based on diagnostic criteria, you can't really rule in any psychiatric condition until you rule out medical condition. It says unless related to medical condition. So with every kid, I would try to do my best to rule out any medical condition. For example, again, presenting with palpitations, presenting with anxiety, or my heart is pounding, we immediately think, oh, it's a child is healthy, it's anxiety disorder, and in reality, it's a heart problem that can really be missed. You don't work with elderly people, but the majority of cases that they present with acute psychosis, it's UTI or any kind of infection, or flare-up of asthma or bronchitis, anything. Let's say gastrointestinal symptoms, any symptoms, sometimes present like depression. In reality, it's ulcer. And probably you will see some of the illnesses or some of the syndromes that kids are born with, like extra chromosomes. It will present as ADHD, learning disability, depression, impulse control disorder. I don't know if you can see this or how you can copy this page and keep it. But basically, let's see what can mimic depression. Stroke, tumors, heart failure, pulmonary embolism, cardiac arrhythmia, anemia, increase in calcium, hypothyroidism, Cushing syndrome, Addison's disease, lupus, pancreatic cancer, UTI, all kinds of things, vitamin deficiency, substance use, anything. So until I rule out pretty much everything that's in there, I probably wouldn't be able to rule in depression.